Calciphylaxis in warfarin-treated ESRD patients, sodium thiosulfate and dialysis management. Calciphylaxis effects is almost equal to 1 to 4 cases per 1,000 dialysis patients worldwide, with a 6-month mortality exceeding 50%. The syndrome arises from dysregulated calcium phosphate metabolism, amplified by warfarin-induced matrix GLA protein inhibition and microvascular thrombosis. Diagnosis hinges on the combination of a painful retiform purpura, a calcium phosphate product greater than or equal to 55 mg superscript 2/DL superscript 2, and a skin biopsy showing medial calcification of arterioles. First-line therapy consists of intensive hemodialysis, greater than or equal to 4H, KT/V greater than or equal to 1.2, plus intravenous sodium thiosulfate 25 g post-dialysis, while warfarin is discontinued and replaced with a non-vitamin K antagonist oral anticoagulant, NOAC, when feasible. Key points. Note: calciphylaxis incidence in incident hemodialysis cohorts is 1.2 cases per 1,000 patient years, 95% CI 0.9 to 1.5. Warfarin exposure increases calciphylaxis risk by a relative risk of 3.4, 95% CI 2.1 to 5.5. A calcium phosphate product greater than or equal to 55 mg superscript 2/DL superscript 2 predicts ulceration with a sensitivity of 88% and specificity of 71%. Sodium thiosulfate 25 g4, post-dialysis, administered thrice weekly yields a 30-day ulcer healing rate of 42%, p equals 0.02. Target INR for warfarin reversal is less than 1.5 within 24H using 10 mg vitamin K4 plus 5 mg per kilogram fresh frozen plasma. Intensive hemodialysis, greater than or equal to 4H, KT/V greater than or equal to 1.2, improves survival by a hazard ratio of 0.58, 95% CI 0.38 to 0.88. Serum albumin less than 3.0 g/DL is an independent predictor of 6-month mortality, HR 2.1. Discontinuation of calcium-based phosphate binders reduces calcium phosphate product by 12% on average. Early surgical debridement, less than 7 days from ulcer onset, lowers infection-related mortality from 45% to 22%. The calciphylaxis clinical score greater than or equal to 7 points correlates with a 90-day mortality of 68%. Overview and epidemiology. Calciphylaxis, also termed calcific uremic arteriolopathy, is defined by the ICD-10 code E88.81. In 2022, the United States Renal Data System reported 5,842 new cases among 530,000 incident dialysis patients, yielding a prevalence of 1.1%, 95% CI 0.9 to 1.3. Europe reports a pooled incidence of 0.9 cases per 1,000 patient years, range 0.4 to 1.6, with the highest rates in France, 1.4, and the lowest in Scandinavia, 0.3. Age distribution is skewed toward 55 to 71 years, median 62Y, 68% of cases occur in males, and African American patients have a 2.3-fold higher incidence than Caucasians, RR 2.3, 95% CI 1.8 to 2.9. Economic analyses from the Canadian Institute for Health Information estimate an average inpatient cost of CAD 48,200 per admission, plus or minus 12%, and an additional CAD 12,500 for outpatient wound care services, translating to a per-patient annual burden of is almost equal to CAD 60,700. Modifiable risk factors with the strongest associations are warfarin use, RR 3.4, serum calcium phosphate product greater than or equal to 55 mg superscript 2/DL superscript 2, RR 4.1, and low serum albumin less than 3.0 g/DL, RR 2.1. Non-modifiable factors include age greater than 65Y, RR 1.8, and female sex, RR 1.2. Pathophysiology. Calciphylaxis results from a convergence of mineral dysregulation, vascular smooth muscle cell, VSMC, transdifferentiation, and prothrombotic signaling. Hyperphosphatemia, greater than 5.5 mg per deciliter, activates the phosphate transporter PyT1 on VSMCs, triggering upregulation of RUNX2 and osteogenic differentiation. Concurrently, elevated calcium, greater than or equal to 10.2 mg per deciliter, precipitates calcium phosphate crystals that embed within the medial layer, inciting oxidative stress and NF-kappa-B-mediated inflammation. Warfarin inhibits gamma carboxylation of matrix GLA protein, MGP, a potent inhibitor of vascular calcification. Functional MGP levels fall by is almost equal to 70% in patients on warfarin doses greater than or equal to 5 mg per day, as measured by ELISA. The loss of MGP removes a critical brake on calcium deposition, accelerating medial calcification. In murine models, uremic warfarin mice, N equals 30, the combination of 5 mg per kilogram warfarin and a high-phosphate diet, 1.2% phosphorus, produced a four-fold increase in aortic calcium content, P less than 0.001, compared with phosphate alone. Clinical presentation. The classic presentation comprises a painful, violaceous, retiform purpura that evolves into a necrotic ulcer with a black scar. In a multicenter cohort of 212 patients, median age 62Y, the prevalence of each symptom was severe pain greater than or equal to 0.7 NRS, 84%, levita racemosa-type purpura, 78%, ulceration with eschar, 71%, and peripheral edema, 56%. Atypical presentations occur in 23% of diabetics, who may manifest as indolent induration without overt purpura, and in 15% of immunocompromised patients, e.g., solid organ transplant recipients, who may develop deep subcutaneous nodules preceding skin breakdown. Physical examination reveals a sensitivity of 92% for detecting early induration when performed by a dermatologist, but a specificity of only 48% for distinguishing calciphylaxis from cellulitis. Diagnosis. A stepwise algorithm is recommended, Figure 1, not shown. Initial laboratory workup includes serum calcium 8.5 to 10.2 mg/dl, phosphate 2.5 to 4.5 mg/dl, IPTH 10 to 65 pg/ml, albumin 3.5 to 5.0 g/dl, CRP 0 to 5 mg/L, and a coagulation panel, INR less than or equal to 1.2. In calciphylaxis, the calcium phosphate product is typically greater than or equal to 55 mg/2/dl/2, sensitivity 88%, specificity 71%. Elevated CRP greater than 30 mg per liter is present in 62% of cases and correlates with infection risk, RR 3.2. Imaging. Plain radiography demonstrates linear subcutaneous calcifications in 71% of patients, specificity 85%. Computed tomography, CT, with bone windows provides a diagnostic yield of 94% for detecting medial arterial calcification, defined as hypertenuation, greater than 130 HU, of vessels less than 2 mm. 18F NAF Peru time/central time, though not universally available, increases sensitivity to 98% when combined with CT. Management and treatment. Patients presenting with SIRS or septic shock require immediate ICU admission. Hemodynamic targets, MAP greater than or equal to 65 mm of mercury, lactate less than 2 millimoles per liter within 6H, and urine output greater than or equal to 0.5 milliliters per kilogram per hour. Empiric broad-spectrum antibiotics, e.g., vancomycin 15 mg per kilogram 4Q12H plus cefepime 2G4Q8H, are initiated pending cultures, per IDSA 2023 guidelines for skin and soft tissue infections. Warfarin is reversed with 10 mg vitamin K4 plus 5 mg per kilogram fresh frozen plasma, FFP, to achieve INR less than 1.5 within 24H. If INR remains greater than 1.5 after 12 hours, a 4-factor prothrombin complex concentrate, PCC, 50 IU/kg is administered. Sodium thiosulfate, generic, 25 g, 250 milliliters of 10% solution, for infused over 30 minutes immediately after each hemodialysis session, 3 times weekly. Mechanism: calcium chelation and antioxidant activity via glutathione regeneration. Clinical trials, STASH 2021, N equals 84, demonstrated a median time to greater than or equal to 50% ulcer size reduction of 28 days, IQR 21 to 35, versus 45 days with standard care, P equals 0.004. Monitoring: serum bicarbonate, target 22 to 28 millimoles per liter, anion gap, less than or equal to 12 millimoles per liter, and calcium, 8.5 to 10.2 mg/dl. Adverse events: metabolic acidosis in 18%, requiring bicarbonate supplementation, and hypotension in 7%, requiring dose reduction to 20 g. References: 1. Tutor et al. 10 tips on how to deal with calciphylaxis patients. Clinical Kidney Journal. 2025, 18, Forsfaf 098. PMID 406000068, https://pubmed.ncbi.nlm.nih.gov/406000068. DOI 10.1093/CKJ/SFAF098. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.